And we're on. So this is episode number 6 of the Redefined Health Ed podcast. And I'm so excited to have Dr. Elise Cantu with us tonight. And we're going to just be chatting it up about who she is and what she does and a little bit about Elise. So this is Elise. She is a proud physical therapist practicing in Fort Worth, Texas. She's passionate about oncology physical therapy and her patients, and knows how frustrating it can be to not know where to turn for help on how to best treat oncology patients. Totally understand you on that. Thus, the Onco PT was born, and that's Elise. The Onco PT connects you with the up-to-date information on how to serve oncology patients. If you're tired of feeling frustrated or inadequate in your oncology PT practice, the Onco PT will help you make the journey from novice physical therapist to competent, confident Onco PT. Elise, I'm so excited.
Thank you so much. That was such a beautiful intro. Like, I know I gave you the bio, but I feel like you really brought it to life, which is really great.
Well, that's one of the things I'm good for. I'm good for a few other things. And then there's other things that I'm just really terrible at. So like being formal, we were just talking about prior to jumping on the call about how formality is it's just not something I'm interested in, which is funny because I was in the Army and,
And like, I get that when I first started practicing, because I'm also an Air Force brat. I don't know if you knew that. So I get the whole
I did not
military background and whatnot. And honestly, it's been over the past year and a half that I have just like formalities have kind of just gone out the window. And I'm almost reaching a point, and I know like older people talk about this, like my grandparents talk about this, but I've kind of reached that point of like, life is too short for all the formalities. Let's just get the point across. And how we need it to.
Yeah. I just, I don't really give a shit anymore.
It's my energy is far too valuable and far too limited.
Yeah. We all just need fun in our lives. That's what we need. We need fun. We need less red tape. We could talk all day about that.
I was going to say, do you have another podcast scheduled on that? Because
I could talk all day. So not only was I Army, but I was also, so one of the things that I'm so glad that we connected, because after I got out of the Army, I spent a year at the University of Oklahoma's Cancer Center, as you know, which was a totally, talk about like baptism by fire. As an ortho specialist, jumping in straight into like an outpatient oncology setting. Yeah.
And I would like to say, before people are like, oh my gosh, that's so crazy, like it can be done clearly because Katie did it. But really, I think baptism by fire is a really appropriate way to describe the submersion, but then I think take it a step further and maybe drowning a little bit in oncology, because I've been there.
I for a while, I think, was like fake it till you make it. There are certain, just like there is in every other field of PT and of healthcare in general, you have your kind of simple cases and then you have your really complex cases. My first patient that I got, and I will never forget this man. My first patient that I got was the most like exuberant potty mouth guy, and not only was he that, but he was a medically extremely complex. And I was just like people can't see me right now, but I'm like speechless, like jaws kind of hitting the floor. He had basically a GI. He had a colon resection. He had and his wound from the abdomen, from the abdominal incision, it was diaphoresis. So he basically had a humongous diastasis that was they put a wound vac on and it was not great, and then he was going to wound care and he was kind of doubled over. So I was like trying to figure out how to even get him laying down on the bed. I was so out of my element, and this is coming from the Army, where like, there's a lot of complex cases there, but most of the time I was dealing with like just general orthopedic stuff, ankle sprains, knee pain, back pain, nothing like this. And yeah, so baptism by fire.
Yes. And, even, and Katie, we can get into this more, but, I did a clinical rotation in oncology, and I then went right into starting, I was practicing in an outpatient oncology clinic. And I came in day one, I was like, I know what I'm doing. I know what I'm doing. And my very first patient of the, I know, mistake number one, my very first patient of the day, my very first solo eval as a big person PT was a disaster. Bless this patient's heart, because I was horrible. She actually, it was really interesting. And I don't know if anyone else has really encountered this before. I had a person who had, achondroplasia, which is a form of dwarfism. And she was getting treatment for her breast cancer. And I was kind of convinced, after seeing what we saw, the dosing was like, I don't know how the dosing changes when you have people of different statures. I know chemotherapy is very like body weight based. But I think she was getting like absolutely over irradiated, blasted, because she came into me for shoulder problems. And then when we went to, because this is what I learned in my clinical rotation, like you need to make sure and look at the skin. And Katie, I have never seen such burned skin before in my entire life. Like it was sloughing off. She couldn't wear a bra because it was so painful. And it was just like, the shoulder has to take a back step because we have like infection issues. I mean, like, again, because she was so short,
Yeah.
the radiation was like her whole trunk.
Oh my God.
Whereas on you and me, like I'm short, but like relatively within the normal realm, like the radiation on me would be very well contained. And I walked out of that eval and she was crying because she was in so much pain and she was upset. And I was trying not to cry because I was like, I don't know what to do. So I think everybody is trial by fire.
So
honestly.
So side note, and also like PSA, if you are working with somebody who's getting radiation or they've had radiation semi recently, you need to look at the skin.
Yes.
That was like lesson number one. Like you have to look at it. I don't care what body part it is, you need to look at it and check, make sure.
You never know what you're gonna find.
Oh my gosh. So on that note, now that we've kind of like made everyone really afraid of being an Onco PT, what's your why?
I was the really weird kid. So I lived in a gated community when we moved to Texas, because I shared with you, Katie, I was an Air Force brat. And so my dad got out of the Air Force for a time. We moved to Texas and we lived in a little gated community that had these little street dances. And like there was the pool, there were hula hooping contests, like all kinds of, just like, super fun summery things.
Like a nice community.
And I would go sit in the ambulance and talk with the EMTs. I was just like enthralled. So my mom's an oncology nurse. My sister then went on to become an oncology nurse. And so healthcare was kind of a thing that was on my radar. And so, decided on PT school, went to PT school, but I really didn't gel with ortho or with neuro. And so end of first year of PT school, I really just kind of like, I don't know what I'm supposed to do once I graduate. Like, I guess I'll go be a PT and do something somewhere. But I went to CSM that first year of PT school and I stumbled into a class that was oncology physical therapy taught by Amy Litterini and Nicole Stout, who are some of the big, oncology names. And I was just hooked. And so I went back immediately after CSM. I went to our director of clinical education and said, I don't care what you have to do. I need to do oncology. And so the stars aligned. I had this amazing clinical rotation, found a job. I think cancer sometimes scares people a lot because it's the C word. It's
a C word.
It's scary, and it is scary, but it was a dinner conversation growing up at our house, which probably speaks a bit to my sense of humor, but it was very much like cancer has never been scary to me in that sense. it's kind of been one of those, I really don't understand it. And so I want to learn more about it, which I think is kind of what piqued some of that. Cancer also kind of runs in my family. I have a grandmother who is a 3 different cancer survivor.
Wow.
My godmother, who I've actually interviewed on my own podcast, is a cancer survivor. It's very much something that it's just been around me, and I'm not afraid of it as much as I just want to beat it down. And this is how I can do that. This is how I can contribute.
Yeah, that is amazing. So you kind of just clicked with Onco
Oh my
PT,
gosh,
like,
yeah.
pretty early on, which is
Yes.
kind of the contrary. So you're talking about oncology and cancer being scary. Yeah, I was like scared to death of cancer because in the orthopedic world, excuse me, in PT school, but then also, especially when you get into more post-professional education, everybody talks about screening for red flags. And, cancer literally is the C word when it comes to red flags. And in the orthopedic community, it's like this big taboo thing, like, oh my gosh, it's cancer. And then nobody else talks about what to do with it. And it's hilarious. It's not hilarious, but it's sad that as an orthopedic specialist, I really did not have any training in like how I can manage the orthopedic conditions of individuals with cancer or who are surviving cancer. And after my experience at OU, I'm so passionate about working with this topic, or I'm sorry, working with this population and helping the rest of the orthopedic community see that we need to know this stuff.
Right.
We need to be better with this because not only is cancer rising in prevalence, you probably know the stats better than I do, but there's more people living longer with cancer and or surviving, going into the survivorship continuum.
Yes.
So we're going to see them regardless.
And, Kristen Carroll, who is part of the team at Survivorship Solutions, she said something that just knocked my socks off within the past year. It was like, you may not think you see these patients, they see you. They are coming to you. The very first person I ever encountered with a history of cancer was in my very first clinical rotation. It was outpatient orthopedic. It was nothing special. And I had multiple patients who had been treated for cancer at some point in their lifetime. And I had no idea what that meant long term. When I first identified that this was something I wanted to do, it was, I'll work with people during treatment, with no appreciation whatsoever for what treatment and what cancer does to a person then and there, but also for the rest of their life, whatever that looks like. And that's where we spend so much more of our time. Katie, I just went to PT. For me, I was having TMJ issues, and I had multiple conversations with my own PTs about, are you seeing these patients? Okay, what are you doing with these patients? Like, that's an outpatient, very musculoskeletal orthopedic heavy patient population, and they're seeing them. It's not just these big cancer hospitals or oncology, centers. These patients are stumbling in, hopefully not stumbling, but sometimes stumbling into clinics and facilities everywhere. Right. And we are all going to see them. So you need to be comfortable with them.
Right. And so at OU, we would have people that would come from like 4 hours away for treatment.
Yes.
And so we would see them and we'd be like, okay, so are you coming back? When are you coming back? Like, and then we would try to set them up with other PTs in their community or with home care if needed. But if somebody doesn't know how to, it can be very intimidating.
Yes.
So why do you think it is? I've always wondered this. Why do you think it is that, like, in our neuro and because cancer is interesting because it affects literally every body system. It is not just neuro. It is not just ortho. It is not just, autoimmune. It's not one thing. Cancer affects and its treatments affects every body system. So why is it that we don't learn more about cancer when we learn in PT school? Like when we're in our neuro class, when we're in our ortho class, when we're
Mhm.
in our whatever, why is that not integrated?
The really unfortunate and maybe bureaucratic answer to this is it's not tested. So current landscape is CAPD, which is the accrediting body for at least PT schools. I'm less familiar with PTA schools, so I can't really speak to that. But cancer is not like what's asked about when it comes to cancer on our licensure exam is, can you identify red flag conditions? Number one, I feel like, is cancer. I mean, when we were learning red flags in PT school, the first one we learned about was cancer. And I think right after that was like tethered cord syndrome or something. Like these horrible, scary conditions that could like paralyze a person. And that was my exposure to cancer in a patient from the learning side of things is this could kill a person, which we have to respect that cancer can, okay? But it's not an automatic death sentence for everybody, like I think we are led to believe in school, at least in the program that I went to. And a lot of the people that I encountered through my work is cancer is scary. And this is both PT and PTA programs, unfortunately. So the short answer is it's not tested right now. Because it's not tested, there's no incentive, unfortunately, for the schools to teach this. And the priorities lie elsewhere. I was actually just having a conversation with my husband the other day about, we had so much research. We had a very research heavy program that I think could have been cut in half, honestly, and could have been substituted with really important other
Pragmatic topics.
Oncology.
Yeah.
Oncology and lymphedema, pelvic health, pelvic floor, vastly. And it's the same thing. It's really not tested. And so if it's not tested, there's no incentive for the school to teach it, except maybe through an elective course or maybe an optional, evening lecture given by a local practitioner who's just really passionate about this patient population. So it really leaves it up to the individual, the student, or the, now clinician, to go out and find this information on their own.
And on that note, I know that when I started at OU, having known nothing about cancer, there's courses out there. There's definitely some out there, but it's not nearly as much or as in depth or as readily available as, some of the more mainstream things. So I'm curious to hear what the Onco PT is doing with regards to oncology education.
Yes. So I shared with you my very first eval, which even with a amazing clinical rotation that I had, I still started and I was practicing in a setting. I was the only therapist. So there were like multiple issues here, but I still was so lost. And I decided after struggling through for like 4 months, I didn't want anybody to ever feel that way again. And so I basically combined my love of oncology physical therapy and my love of podcasts. I'm a very voracious podcast listener. So I said, why don't I just combine the two? And so it's led me down a now 2.5-year journey of, I don't want any physical therapist to not feel like they can help the person in front of them in whatever small way, that they cannot help the person who has cancer, who has a history of cancer sitting in front of them. Because at the heart of all of this, there is a person. There's a human being sitting in front of you that you have the skill set to help. If you don't know all the ins and outs of cancer or cancer treatments or what they do to a person, but you can help that person. And we need to empower and equip more physical therapists to take that step. Because Katie, I really want to come back to something you said is there's some courses out there. There's some really fantastic programs out there. But a lot of it, I think, is catering to the practitioner who wants to be a oncology specialist, an oncology expert. And we need more for the general physical therapist. And I say that with the utmost respect, not like, the plebe. That's not at all what I'm saying. It's like, for someone who does not want to specialize in oncology,
Yep.
What do I need to know to get by?
Yeah. What are the bare bones basics?
Exactly.
Triple P. Maybe we could come up with some sort of tagline on that. Bare bones basics of Onco PT for the generalist.
Yes. So that's what I'm doing now.
Yeah, awesome. So, so on that note, just a little plug here. Elise is teaching for Redefined Health Education. She has a course coming up on Wednesday, July 28th. It's the New PT's Guide to Cancer. So if you're that generalist that we were just talking about, which really was me prior to starting at OU,
Absolutely.
I was totally that person. And so I'll kind of like backtrack. So again, Wednesday, July 28th, go to redefinedhealthed.com and sign up for that. But I was that person that actually I had somebody who it's a very sad story, but when I was in the Army, he 37-year-old male, I'll never forget him. I remember his full name. I remember his birth date, which is like, I just remember so much about him because it had such a big impact on me. And he came in and he just had hip pain. He had really weird hip pain. His hip pain was not typical, like in the inguinal region or wrapping around in the glute or down the side of the thigh or lateral or whatever. It was right here. And for those listening, I'm pointing to the like top of my ilium, basically a little bit posterior to the ASIS. That's where his pain was. And it was only reproduced with a single leg hop. Nothing else that I did reproduced his pain except for that impact. So I was like, this is just too weird. We'll just forget that happened. I was like, this is too weird. It's gotta be something. So he ended up having routine imaging done anyways, because I was at a basic training installation. There's tons of femoral neck stress fractures. So he had an x-ray prior to even coming to see me, but it wasn't red yet. So I pulled up his imaging and I was like, what's this? So he had a radiolucent spot on his ilium. It was like, pretty good size. And long story short, I ended up just giving this guy my personal phone number. And I was like, which I don't recommend doing, but I did it at the time because I knew that he was going to get lost in the system because I just knew how it worked. And I was like, we need to follow up on this like right away. And he ended up having a very advanced stage 4 angiosarcoma and passed away 6 weeks later. So that case had such a profound impact on me and just him and the process. Like he had a wife and a 10-year-old, and it just had such a big impact on me that when I saw the job opening come up for the cancer center, I was like, I wonder like how I can help people that are, maybe they're just diagnosed with cancer. Maybe they're at the end of their cancer journey. And how can I make their life, even if it's in their last days, or even if they're on that road to recovery where they get to ring the bell and they're done with their radiation and their chemo and stuff. Like I wanted to be a part of that. And I have to tell you that was my most favorite, best career experience. And I ultimately would like to go back to that setting. I'm sad that I left it. But this is
the most rewarding experience clinically I've ever had is in that patient population.
I was concerned that going into that setting that I would just be surrounded by death. And it's like that. It is not like that. Of course, there is, people die from cancer and patients want to talk to you about dying. And that's okay. And I needed to learn all of that. I had some awesome peers that I leaned on heavily. But so if you're in an outpatient setting and didn't Jimmy do a podcast on what to do if a patient asks you about dying?
Yes. And I'm so glad he did that. That is so important. And it means the world to me that we are having these conversations.
Yeah. Tell me about that. Have you ever had any like tough cases like that?
Oh my gosh. Yeah. Where do you want to start? So for those of you who are listening, who are like, oh my gosh, cancer is so sad. Yeah, it's sad. There are some really sad moments, which we'll go into more, but there are some of the most precious, beautiful moments. Yes. Thank you, Kate. Beautiful moments between you and another human being that I don't think we get to experience in other settings, in other patient populations, and other dynamics. And it's very, very precious to me. And so, Katie, I had to laugh when you said you gave that patient your phone number. All of my patients, like as soon as I feel like we're developing rapport, they get my cell phone number. I have some who still text me a couple years later. I have one patient actually right now who I absolutely adore. She's no longer my patient, but she has stage 4 breast cancer. And so stage 4 breast cancer stage 4 cancer period doesn't have great prognosis. Unfortunately, stage 4 breast cancer tends to have a not as great prognosis when you look at kind of big picture here.
Right.
And so we know we're working with a timeline. There is a very finite timeline. And she will still text me and will give me updates. Like she's been in and out of the hospital a couple times over the last year. It's been very scary, in light of COVID and everything. But her texts give me such joy to know, because ultimately what that tells me is that I was supposed to meet that person at exactly where she was at, exactly where I was at, and that I am important enough to her, which is not because I'm a super great person or anything, but I am important enough to her, or I made enough of an impact on her life that she chooses to stay in contact with me. And I have multiple patients who do that, which is, I don't feel like you get that in other settings. Like in ortho, someone has a surgery, they see it for a while and they move on, which is great. I want them to move on. Great. Oncology is a little different. Even my patients who, they finish treatment and then they are disease free and they're done, like they're considered in remission, they still come back and see me. And that is it's just so cool. And honestly, I have to keep smiling about it because I also am like a very emotional person and I do like to cry. Damn. So if I'm kind of in this weird like face on camera, or those of you who are listening hear my voice kind of fluctuate, like there's a lot of emotion around this and it's all good. Like I'm very comfortable crying. I'm very comfortable sharing these emotions because I also want to be open and to say like, it's okay to have these feelings. I worked with, unfortunately, a case manager one time in the oncology setting who was, I think, very jaded and was very crass towards the whole mortality experience. And I never want to be like that. We touch these human souls in such brief moments of time. I don't ever want to not appreciate and acknowledge the preciousness that is that human life. And so sometimes we grieve over it. Sometimes, I have patients pass and I will cry.
Yeah.
And ultimately, I do what I need to do to get through the day. And then I can come home and maybe I acknowledge my grief in a different way. And then I can get up the next day and ultimately I can keep going because I know that I'm making a positive difference in those patients' lives.
Yeah.
And like you said, I have worked with patients all the way from newly diagnosed to the end days of their life. And I think one of the things that really flipped a switch for me is I was working with a fabulous massage therapist. Oh my gosh, I just adore her. Everyone needs a joy in your life, like joy, like I had joy in mine. And she made the comment, because I was really bogged down with, I had a lot of patients who had very advanced cancer and was like, man, this like sucks.
1 second. I'm gonna just. Okay,
so I had this
pause.
Just amazing massage therapist that I was working with. And at the time I was really frustrated and kind of didn't know how to process the emotion. This was earlier, obviously, in my career, but I really didn't know how to process the emotion I was feeling towards. I had a lot of patients who had very advanced cancers and it was really weighing on me psychologically and I didn't know how to handle it. And Joy, this massage therapist, told me, she says, but they are choosing to spend their limited last moments with you. And that like knocked me on my butt, Katie. And immediately, just light bulb, complete 180. And from that moment, it was like, whoa, because she was absolutely right. Those patients don't have to come see me. They can see peace and go do whatever, water ski or who knows what else, but they were choosing to come to PT to see me so that I could help them. And that was a real catalyst in kind of approaching these maybe more sad, more, depressing, emotionally draining cases.
Yeah. So that's what's interesting, and something I was thinking about is I remember nearly every single patient that I had at the cancer center who passed. I remember them. I remember their names. I remember their faces, and I remember the activities and like the types of therapies that I was doing with them. And
Mhm.
I remember them being excited about little accomplishments, even though they, for the most part, all knew that they were kind of approaching end of life and that there was a timeline, but they still were just so happy about the little things.
Mhm.
And those moments meant so much to me. And I know that they meant so much to them because it was just like that little bit of, they were still accomplishing something.
Yep.
And I don't know if you listened to episode 1 or episode, like I kind of had part 1 and part 2, but I was talking to Rachel Newhold,
Yes.
who was one of my peers at OU, and
Mhm.
she had this one patient who was in his mid 30s, and it really was his last visit with her, and he just was in a lot of pain, and he decided to come anyways, and he really liked working with her. It was just I remember him too, and yes, that case was sad. It's almost like gut wrenching if you weren't there,
Mhm.
but being a part of it and being a part of somebody's happiness,
Yes.
even in their final days,
Yes.
means the world. And I can tell you, like, I've had a lot of orthopedic cases, way more ortho cases than I ever had onco. And I don't really remember any of them.
Mhm.
I mean, maybe like onesie twosie here and there, but like I
Yeah.
remember almost everybody that I worked with at the cancer, because the treatment and the conversations and what was happening when we were there was so much more impactful. I
Yeah.
don't know. It's something that I hope that every healthcare practitioner experiences. And when you work in an onco setting, or you work with somebody who has cancer,
Mhm.
has had cancer, you get to sort of walk that journey with them, and it's really meaningful.
Uh, I mean, that this could be a whole other podcast episode of like, and I said this earlier, it is so rewarding to get to rejoice in the little wins that they have,
Yeah.
because they mean so much more than, woo, I got to 135 degrees of knee flexion today. Like, I don't know. I've had maybe one patient who was super stoked about that in an ortho setting, but man, I had a patient who could stand up to scramble eggs for herself for the first time in 3 years.
Mhm. Yeah, there's
Scrambled
a
eggs.
little bit of
But
difference.
that was the world to that patient. How
Yeah,
cool is
amazing,
that? Ah,
amazing. So I want to just throw out a little note here. So one of the things that I love so much, my Army experience, I was actually embedded in a primary care clinic. So I was in an interdisciplinary setting. And then moving into the cancer center, I also got to experience the importance and the benefit of multidisciplinary practice.
yes.
And which basically, like, for those of you who don't know this, and I guess I never really experienced before, but every specialty, every onco specialty would have their own, like, they call them tumor boards every week. Actually, they were every week. And so all of their new cases, they would review the case upon diagnosis. So like as soon as they got a new patient in, it was like the medical oncologist, the radiation oncologist, the surgeon, the PT, anybody who was going to be involved in that patient's case was present,
Yes. Yes.
discussing care. I mean, should that not happen across the spectrum of healthcare? Because I think it should.
It
And
totally should.
so this topic of multidisciplinary, interdisciplinary collaboration and practice is something that I am extremely passionate about. And from an education perspective, I think it absolutely needs to be happening more. So we have this awesome free event on Wednesday, July 14th. And we have two awesome groups. We have a group from Yale, from the Yale Cancer Center, I'm going to butcher the name because I didn't brush up on it before this. So I'm just going to say the Yale Cancer Center.
The Yale Smilo Cancer.
Milo, yeah, something. I know. I knew it was something like that. I just didn't want to say it. But we have this awesome group from there. So it's a PT, a oncologist. I think she's a medical oncologist.
Yes, if it's who I'm thinking of. Yes, it is the medical oncologist.
Medical oncologist, PT, dietitian, PA, behavioral health.
Yes.
I think from there. And then we also have Cancer Rehab Austin is going to be there. So there's PT, an acupuncturist, I think a dietitian. And again, I'm totally butchering both sides because I didn't brush up on it because I'm a terrible podcast host, but it's free event. And we're going to be talking, like, these two groups of individuals are going to be talking about basically their whole model of care and how they work together to treat patients in an interdisciplinary setting. It's amazing. It's going to be awesome. It's going to be
so cool. And Katie, you really did a great job of curating this from two very different like sides of the equation. So the Yale Smilo cancer group, they are very much, a little more, it's a survivorship clinic. So at this point, the patients that they are seeing have finished with their active treatment. And now they're in this, okay, what do I do for the rest of my life potentially? Because it doesn't okay, you're cured of cancer.
Right.
And then what? And unfortunately, we have a lot of patients who really just fall through the cracks. And Katie, to get personal right now, my grandmother was actually, they found that she has a spot on her lung that has grown. And this is why I bring this up. The importance of survivorship care, long-term survivorship care is critical because she hasn't been into her oncologist in like a year or two. And she was one of those patients who just fell through the cracks. And it's hard to say now, like, where will we be? Where will we be in a year? But like, this is really important because this is not an isolated event. Long-term survivorship care is critical. It is overwhelmingly lacking in our healthcare system, period. And the Yale Smilo group is really working to fix that. So we've got this big cancer institute who is doing this. And then on the flip side, we've got Angela Wicker Ramos and her team at Cancer Rehab Integrative Medicine in Austin. And they're doing this from a private practice. And it is so I just adore both of these groups. I know them. I know some of their team and I just adore them so much. And no matter where you're at, like if you're at an outpatient clinic, if you're in a hospital, if you're just trying to figure out, do I want to even delve into oncology, or yes, I'm really on board. This interdisciplinary panel is going to be rocking and I'm so excited for it.
And I'm like a little worried that like we're not gonna have enough time. Like I just feel like this is gonna end up. I don't care. Like it can go all night long. We'll just party all night long.
I'm so pumped. Like you got a good group. You got a really.
So everybody go it's free. First of all, so go stink and register. Redefinehealthed.com once again. And that's going to be just a few weeks before Elise's new PT's Guide to Cancer course. So, register for that too, because it's going to be awesome.
We're going to hit the 3 B's, the bare bones basics of what is cancer, what is cancer treatment, and what do we need to know about it? Even just like get started with this person.
Oh my goodness. I'm so excited. So we're kind of like right at the 45-minute mark-ish right now. Elise, I would love for our listeners to know how they can get in touch with you and how they should follow you. So throw out all your plugs now.
Absolutely. So I am at the Onco PT on Twitter, Facebook, Instagram,
TikTok. You're talking it on TikTok.
My gosh.
You're doing really good.
My TikTok game is a little lacking, but that's okay. I'm gonna get it back up on par with Katie's.
I know. Me too. I like quit and then I'll start back up. I will.
Yep. Same thing. So yes, on TikTok, but don't get your hopes up on that right now. I do have my own podcast, which is called the Onco PT Podcast, where I empower and educate physical therapists how to be confident and competent treating a person who has cancer or has a history of cancer. Because again, to quote Kristen Carroll, you may not see them, but they see you, and they are going to be coming to you. So you need to be ready for them.
Yes, totally. Thank you so much, Elise. This was really fun. I feel like we could probably talk all night long about.
You know me, girl. I can talk forever about cancer and cancer PT.
So could I, which is funny because I really do consider myself like an ortho. That's my bread and butter. It really is.
That's what you think, but we're gonna bring you to the dark side.
I know, and I like, can you do both? And I think yes. And I think you can be very, in fact, I actually think that my skills, again, this is like going to start a whole nother podcast. My skills that I gained as a very competent orthopedic specialist prior to going to the cancer center only set me up for success. Like the evaluative procedures, it just goes a little bit more in depth and it gets a lot more medically complex. So your skills as far as like assessment and as far as medical knowledge in general just goes to another level. So ortho PTs, step up your dang game.
You know, and Katie, I've said this before on my own podcast, but I didn't realize when I started this journey, I knew I wanted to specialize in oncology. I didn't know how much of a generalist I would need to be as an oncology physical therapist, because you hit the nail on the head. Yeah, I treat oncology, but I treat a lot of neuromuscular, a lot of musculoskeletal, a lot of orthopedic, sometimes a little wound care. Oncology affects every
system,
part of that body.
Mm-hmm.
And as such,
pulmonary, GI,
cardiopulmonary,
ortho, everything. I think we had a bunch of like brain. We had a lot of brain tumors, and brain tumors are space-taking lesions. They look like strokes. They look and act and walk and breathe like strokes.
Yes.
So neuro people, get on your little game too.
Mm-hmm.
Oh my God, again, we could talk all night, but we'll just end there and then we'll do another one,
Perfect.
Do it.
This is fun, Katie.
So fun. Take care. That's a wrap for episode 6, and goodbye.